Dr. Yang is a graduate of Massachusetts Institute of Technology and Harvard Medical School, Health Sciences and Technology Society. She's a clinical pathologist, formerly of Massachusetts General Hospital, where she practiced, taught, and authored in basic science, toxicology, pharmacokinetics, and laboratory medicine. At LabCorp, Dr. Yang works closely with our scientists at our immunology specialty lab in Calabasas, California, as well as expert clinicians on various research and development projects to validate specialized assays, investigate their clinical usefulness, and provide understandable and actionable diagnostic data. Please welcome Dr. Yang.
Hello, everyone. Welcome. Thank you for joining. Today, I will discuss therapeutic drug monitoring, or TDM, which is the clinical use of drug concentrations in blood toward the goal of maximizing drug efficacy while minimizing adverse effects. Today's topic is specialized TDM, because I won't be discussing conventional TDM for the usual traditional medications like digoxin or gentamicin. The greater part of this talk will focus on biologic drug measurements, but other specialized TDM, including the polyglutamate forms of methotrexate and whole blood hydroxychloroquine, will also be covered. The value of TDM is always predicated on the existence and the demonstration of a well-established relationship between what we're measuring, that is blood concentrations, and a desired clinical effect at the tissue level. For example, we can't sample cardiac tissue to evaluate digoxin dosing. So we make an assumption of a parallel relationship between the blood and the tissue, and then we collect evidence that blood drug concentrations are actually a meaningful and accurate reflection of what's going on. Furthermore, I always say that just because we can measure a drug level doesn't mean that we know what to do with that number. So that number has to have meaning, and there have to be well-established targets defined in specific patient populations that show greater response at higher drug levels. By the same token, we need to know thresholds or cutoffs associated with toxicity. So of course, not all drugs require TDM. So what makes a good candidate for therapeutic drug monitoring? Good candidates are drugs that have highly variable pharmacokinetics. A narrow therapeutic index means that toxic doses run dangerously close to therapeutic doses. So digoxin, gentamicin, cyclosporin, these are the classic examples of drugs with narrow therapeutic indices. Good candidates for monitoring are also certain drugs used indefinitely to treat lifelong chronic illnesses, where patient compliance can be imperfect or even poor. Also, when a drug is slow-acting or has a delayed clinical efficacy, TDM can be a helpful objective assessment of patient adherence. Always, the objectives of TDM are to maximize drug efficacy while minimizing adverse effects, and those adverse effects include drug waste and wasted time. These diagrams are really here just to demonstrate the vast differences between conventional small molecule drugs, which are on the order of hundreds of daltons in size, versus biologics. Here we see the TNF inhibitors are on the order of 150 kilodaltons. So not only are biologics 1,000 times larger in size, but biologics are also often proteins, and it's important to remember that proteins have tertiary and quaternary structures that are very important to their function. Also, from a laboratory perspective, TDM for conventional small molecules is straightforward and analytically simple. On the other hand, biologic TDM is a very different animal and much more challenging for the laboratory, as it involves the detection and the quantitation of proteins. And in this case of TNF inhibitors and anti-interleukins, anti-integrins, these drugs are also antibodies with important epitopes. Therefore, we believe that the best way to measure these biologic drugs is by high-caliber immunoassay. And actually measuring biologics is much more akin to measuring protein hormones like growth hormone. It requires tremendous expertise in protein chemistry, immunoassay design, and a deep understanding of immunogenicity. So LabCorp has a true center of excellence for all of this, and all of our biologics monitoring have been developed in-house and are performed at this specialty lab that is located in Calabasas, California. Biologics are prime candidates for TDM because they are precious. Biologics are precious not just because they are expensive, but because they are relatively few. At their best, biologics are life-changing, but unfortunately, patient response is variable and the longevity of response is suboptimal. Biologics monitoring is also useful because biologic drugs always have the possibility of forming anti-drug antibodies, which can adversely affect drug efficacy. So as we'll see, TDM is necessary for detecting and managing immunogenicity. For us, biologic TDM, also called biologic monitoring, is always one test that is two assays performed in tandem. One to evaluate the biologic drug concentration, which is reported in micrograms per mil, and a separate assay for the concentration of drug-specific antidrug antibodies reported in nanograms per mil. Next, I'm going to present two cases of therapeutic drug monitoring in rheumatoid arthritis. One will be a secondary loss of response and another case of primary non-response. Each case will have two different TDM result scenarios, and we'll see that it is the drug and the antidrug antibody level together that is the only way to discern what's at play in drug failure. Either antidrug antibody formation or pharmacokinetic insufficiency versus true mechanism of action mismatch, which may not be as frequent as people think. This is the first of our two cases to illustrate biologic TDM in action. This is an older woman with long-standing RA. 3 years ago, you put her on her first biologic, adalimumab, and she did very well for a couple of years. So well, in fact, that when she asked, you agreed to taper her dose to every 3 weeks. And she did well for a while. But now she is flaring with tender swollen joints and morning stiffness. You're wondering what to do at this time. Should you just put her back on every other week dosing? Should you add methotrexate? Or is it time to switch the biologic? And then switch to what? Another TNF? Or a different type of biologic altogether, like ustekinumab? You order a biologic TDM, and this is one possible set of results. Here you see in the upper graph, the drug level is 3.5. This is low, based on clinical studies in rheumatoid arthritis patients that had demonstrated that a therapeutic cutoff is at least 5, maybe even 8. At the same time, the anti-adalimumab antibodies are 257. This number alone is meaningless, but our lab provides a designation so that we know this number is an intermediate titer. Taken together, this patient has what I call early immunogenicity. Her antibodies are high enough to have started to impact the free drug level, but there is still some active drug in her system, and the antibodies at this level may actually be reversible. So this is a patient you would want to put back on every other week dosing and possibly add methotrexate if it's not already on board, and perhaps check to see if anti-adalimumab antibodies diminish over time with the free drug level rebounding, and of course look for an improvement clinically. On the other hand, if in this same woman you get back this set of results, you can see here the drug is nil, and the antibodies are very high, in excess of 2,000. These results indicate what I call refractory high titer immunogenicity. It's time to move on to a different biologic. But which biologic? Well, you know that in the past, she's been a good TNF responder, so you can try another TNF inhibitor, since the drug-specific antibodies won't cross-react. But with the caveat that you know that this particular patient's immune system is primed to make antibodies. So for example, it may be advisable to monitor more frequently and to add the next TNF inhibitor together with methotrexate. This is our second case. He's a man who has never been on a biologic. You started him on his first biologic 6 months ago, standard dose, and he's never responded. His vector score is actually worsened. So what's going on? Can the TDM help you figure out? Is he a true pharmacodynamic TNF non-responder or not? So you order the TDM and you get back this set of results. Here the drug is low and there are no antidrug antibodies. This is a classic case of pharmacokinetic insufficiency. There's not enough drug on board for this particular patient, but why? Of course, we know that one size fits all doesn't really work. There are just too many reasons why a standard dose or a dose calculated based on a patient's weight alone does not reliably result in the desired clinical effect. Male gender, a lot of adipose tissue, low serum albumin, high disease burden, that patient is just going to need more drug to respond. Biologics exhibit tremendous pharmacokinetic variability, both inter-patient as well as intra-patient variability. That is, the same patient's dose requirements can change over time, when he is flaring versus when his disease is relatively quiescent. In fact, we know from numerous studies and our own clinical database of tens of thousands of patient samples that a significant portion of patients on standard dosing are going to be subtherapeutic. A third to 1/2 of patients who are negative for antidrug antibodies have drug levels that are less than 3 for infliximab and less than 5 for adalimumab. These results indicate here pharmacokinetic insufficiency, insufficient drug exposure. This is not the same as saying that this patient is a true TNF non-responder. So in this gentleman, if you get this set of results instead, here you see that the drug is high. And what does this mean? Well, first of all, you have to confirm that the blood was actually collected at trough. So what do we mean by trough collection? Trough collections of blood should be done just before the next dose, so just before the next infusion or injection of medication. We want drug trough concentrations because they tend to be less variable than at other times during therapy. And almost all of the clinical studies that we have that define our concentration effect curves have been done using drug trough concentrations. So drug targets are always set using trough concentrations. If you do go back and you confirm with the patient that in fact it was drawn at trough and is the trough concentration, we can definitively say that that is high. It is well past a threshold of 5 or even 8 for adalimumab. So these results indicate that this is actually pharmacodynamic or mechanistic or mechanism of action mismatch. This patient may truly be a TNF non-responder. That is, his disease is not TNF driven. And so he is a patient who would be better served by a biologic of a different mechanism, such as an anti-interleukin like ustekinumab. So with these two cases, the woman with secondary loss of response after tapering, and this man with primary non-response, and the 4 different possible TDM result scenarios, we can see that drug failure presents us with a variety of clinical choices to make around medication. We can increase the same biologic drug, we can add a co-therapy like methotrexate, or we can switch the biologic drug. And if we switch, we can switch in or out of class. So how do you make these very different clinical decisions? To increase drug or to switch biologic? it is really the drug level and the antidrug level antibody the antidrug antibody level in biologic TDM that gives you a precise patient-specific tool that can help inform and expedite the right clinical action. As wonderful as biologics are, there is a significant failure rate, primary lack of response, as well as secondary loss of response. So up to a third of patients fail to respond in the primary setting. And of those that do, about half will drop off the biologic in a year or two, and another 10 or 15% will fail every year thereafter. So biologics are what I call precious silver bullets. They are expensive and finite in durability. And furthermore, once a patient has burned through a biologic by developing, for example, high titer anti-adalimumab antibodies, there's no going back. That Humira silver bullet is gone forever from that patient's arsenal. It's not easy to tell who is failing or who will fail a biologic. And unfortunately, all biologic failure looks alike, despite, as we've seen, the very different underlying mechanisms of failure. So it is really TDM that's providing you the drug level and the antibody level, which give you pharmacokinetic and immunogenic insight that you cannot ascertain clinically. So to me, biologic TDM is really a valuable and it's a very underutilized tool. And there's really no downside to doing the biologic TDM. It should really be used to inform the underlying mechanisms at play and to expedite decisions around medications, how to optimize dosing, how to determine co-therapies, and how to guide biologic switching. Of course, like the drugs themselves, the biologic TDM measurements are complex, and as such, they're highly dependent on the laboratory's expertise. As mentioned, we always do the biologic drug concentration and another assay to evaluate the antidrug antibody concentration in tandem. So when a patient taking a biologic drug, as seen here in purple, develops antidrug antibodies, seen here in blue, these antibodies bind to biologic drug and form drug antibody complexes. And then it becomes important to consider what are the clinically relevant measurements. In this scenario, only the free antibody unbound drug is pharmacodynamically active. At the same time, it is the total antidrug antibodies, both neutralizing and non-neutralizing, that can negatively impact active drug by preventing drug binding to target and/or by increasing drug clearance. So it is free drug and total antibody that are the clinically relevant measurements that together provide pharmacokinetic and immunogenic assessment that cannot be ascertained clinically. Simply put, there are only 3 reasons why a biologic drug will fail, either as primary lack of response or a secondary loss of response. There's either not enough drug, the wrong type of drug, or the formation of antidrug antibodies. In pharmacokinetic failure, the drug level is low, and that patient could benefit from more of the same biologic drug. In pharmacodynamic failure, there is a mechanistic mismatch. There is sufficient drug exposure as evidenced by the high drug level measurement. In the presence of antidrug antibodies, one needs to evaluate the titer. And again, you may suspect that a given patient is developing antidrug antibodies, but the blood test is the only way to know for sure. Right here, I just want to note that there are a number of new tests on the market that attempt to identify upfront which patients will and will not respond to a certain type of biologic. Namely, they are response predictors. They're trying to identify TNF responders versus TNF non-responders. And I just want to say that these new response predictors need to be carefully evaluated in light of what we've just learned about drug and antidrug antibody levels. Though antidrug antibodies can form at any time during therapy, in most primary failure, there are two mechanisms at play: pharmacokinetic insufficiency and then true mechanistic mismatch. These are discernible by the patient's drug level. The drug is either too low or the drug is sufficient. And a very significant portion, as we've seen, of primary non-responders just have low drug levels. Unfortunately, these patients may be miscategorized as true mechanistic non-responders if the drug levels are not being taken into consideration and if the clinical study subjects have not had the opportunity for dose optimization. So unfortunately, I think that some of these products may actually be miscategorizing too many patients as true pharmacodynamic non-responders when in fact those patients could benefit from dose optimization before a TNF therapy is ruled out for them. Immunogenicity is the formation of antidrug antibodies. Unfortunately, all therapeutic proteins have the potential for inducing antibodies, and these antibodies against the drug can first appear at any time during therapy. And we know that as antidrug antibodies go up in blue, the concomitant amount of active drug in purple goes down. Unfortunately, immunogenicity rates are significantly high, especially with the older biologics that we have. In the past, the thinking about antidrug antibodies was binary. No, you don't have them, or yes, you have them, you need to switch. In other words, any amount of antidrug antibodies ipso facto was reason to switch the biologic drug. Now we know that low concentration titers can have little or no effect on free drug levels or drug efficacy. They can be transient and they can go away on their own, or they can even be treated away. But left alone, low titers are more likely to progress to high titers, and it is the high titer antidrug antibodies that are more impactful, that adversely affect free drug levels and drug efficacy. So given this more nuanced understanding of immunogenicity, the onus is really on the laboratory to provide the best possible antidrug antibody measurements. Toward this end, antidrug antibody titers should be designated by the lab as follows. The graph that you see here has been generated from our own clinical database of over 2,000 patient samples. The higher the total anti-infliximab antibody, as seen here in blue, the lower the concomitant free infliximab drug level, as seen here in purple. The demonstration of this inverse relationship confirms that both our drug and antidrug antibody assays are working as intended. By analysis of this inverse relationship, we determine cut points. When anti-infliximab antibodies are in excess of 1,000, almost invariably the concomitant free drug is very low or nil. These are high titers. When antibodies are 200 or less, the average free drug is preserved. These are low titers. Antibodies between 200 and 1,000 are intermediate. As our collaborators at Cincinnati Children's have shown, low and intermediate titer anti-infliximab and anti-adalimumab antibodies, as measured by our assays, are often reversible. Green and yellow zones here are a window of opportunity during the early stages of immunogenicity to increase dose and/or add methotrexate or thiopurine to treat away antibodies and look for restoration of clinical response. Therefore, high-resolution antidrug antibodies may be the key to detecting early immunogenicity and reliably monitoring its successful reversal. This algorithm incorporates both reactive and proactive indications for TDM. So when a patient is not responding to the drug, here seen on the left, either as a primary non-response or a secondary loss of response, you first need to evaluate what the drug concentration is. If the drug level is sufficient, then this is evidence of a mechanistic failure. and a switch to a different mechanism of action is indicated. If, on the other hand, the drug trough concentration is low, then you need to look at the anti-drug antibodies. If there are no anti-drug antibodies, or if the titer is very low, then your immunogenicity may still be reversible. If anti-drug antibodies, on the other hand, are high, then you have what I call refractory immunogenicity, and you have burned through this silver bullet. Adding more of the same biologic is wasteful, and it's probably time to move on to a different biologic. The right-hand side of this algorithm illustrates proactive monitoring, that is before symptoms, and this presents a real opportunity to extend longevity, to optimize the drug benefit, and to prevent anti-drug antibodies. TDM may also be helpful in identifying those patients in whom it is safest to try to taper. Another way to think of biologic TDM is that it informs medication decisions. So this table and flow chart have been put together to help you visualize stepwise how you can make decisions as a result of drug and antibody levels. Who can benefit from more drug and who cannot? So dose escalation is really indicated only when the drug levels are low and the anti-drug antibody levels are negative or very low. More drug is not going to benefit a patient who has high drug or high anti-drug antibodies. In summary, biologics are indeed precious, and response and longevity are highly variable and often suboptimal. Drug and anti-drug antibody measurements provide pharmacokinetic and immunogenic insight that can help you optimize biologic use. So moving on from biologics, this last part of my talk will cover methotrexate and hydroxychloroquine TDM. Methotrexate is a cornerstone treatment for rheumatoid arthritis and many other autoimmune diseases. It's a folate antagonist, and it inhibits enzymes responsible for nucleotide synthesis. As such, it prevents cell division, and this may contribute to its anti-inflammatory effects. Methotrexate is given once a week, either by mouth or sub-Q, and it's a very good candidate for TDM because there is tremendous interpatient pharmacokinetic variability, regardless of the route of administration. Many patients achieve only partial response to methotrexate, and as many as 30 to 40% of patients actually fail methotrexate therapy. Evaluation of its clinical efficacy is further confounded by methotrexate's slow action, delays in effects, multiple side effects, and poor patient compliance. Serum or plasma levels of methotrexate have not proved useful in monitoring because the parent drug is rapidly eliminated from the circulation. Instead, there is a growing body of evidence to suggest that methotrexate exerts its anti-inflammatory effect through its intracellular polyglutamate forms. Hence, we actually measure methotrexate polyglutamates in red blood cells as a surrogate for what's going on in the white blood cells. As you can see here, the parent drug methotrexate has one glutamate residue. As such, this parent drug enters into cells, and inside of cells, it's converted to methotrexate polyglutamates by the sequential addition of glutamic acid residues. PG2, 3, 4, and 5 are consecutively formed and retained inside cells with longer half-lives. PG3, 4, and 5 are considered long-chain methotrexate polyglutamates, and these may be the more active forms of methotrexate. Again, we use red cells as a surrogate for white blood cells for the measurements. This is an example of our sample report. We report 6 numeric results. The concentrations of each of the polyglutamates from PG1, the parent compound, through PG5, remembering that 3, 4, and 5 may be more active forms, and we report the total, which is the sum of PG 1, 2, 3, 4, and 5. Considering the sum, we use a cutoff of 75 to indicate who's therapeutic and who is subtherapeutic or intermediate. The sample is whole blood, and we recommend collecting at steady state, which is at least 3 to 6 months into regular therapy, and at least 36 hours after the last weekly dose. If the results show a predominance of PG1, this suggests that the blood collection was taken too soon after the last dose. A predominance of PG3 confirms that the patient is at steady state. And just to note that other labs use a total methotrexate polyglutamate that doesn't include PG1. Our final topic today is hydroxychloroquine. Plaquenil is, of course, that mainstay of treatment that almost all lupus patients take indefinitely. It is also used commonly to treat rheumatoid arthritis and mixed connective tissue disease. Though its exact anti-inflammatory mechanism is not well understood, hydroxychloroquine is selectively taken up by lysosomes and somehow is thought to benefit autoimmunity by interfering with antigen processing. Hydroxychloroquine is related to the antimalarial drug chloroquine, but interestingly, this hydroxyl group on hydroxychloroquine makes it less toxic to the retina than chloroquine because it's less able to penetrate the blood-retina barrier. The daily oral dose of hydroxychloroquine is around 5 milligrams per kilograms, and some doctors actually cap the maximum daily oral dose to 400 milligrams. So hydroxychloroquine works remarkably well. With it, long-term remission of autoimmunity is possible with fewer disease flares, less progression of joint disease and rheumatoid arthritis, and improved survival in lupus patients. Hydroxychloroquine also has protective effects on diabetes, osteoporosis, dyslipidemia, thrombosis, and atherosclerosis. Despite its well-established efficacy, patient compliance is notoriously poor. Reasons for non-adherence include perceived inefficacy, forgetfulness, and concerns about skin hyperpigmentation and retinopathy. Retinal toxicity that leads to blindness is actually very rare, but it seems to occur based on the cumulative exposure to hydroxychloroquine over years and decades. There's an estimated incidence of retinopathy below 1% at 5 years, about 1% at 10 years, about 2% at 15 years, but it jumps up to almost 20% after 20 years of taking hydroxychloroquine every day. Other risk factors include advanced age, renal insufficiency, and a higher daily dose. So for therapeutic drug monitoring of hydroxychloroquine, we actually have very good concentration effect curves. Higher drug levels correspond to better disease control, fewer flares, and improved survival. A level greater than 500 is consistent with efficacy, but recently 1,000 has been shown to be an even better target threshold, with a negative predictive value of 96% for future lupus flares. Levels less than 200 suggest non-compliance and risk for disease worsening. One study found that more than half of patients were non-adherent to hydroxychloroquine more than 80% of the time. Another study of more than 600 lupus patients found that with hydroxychloroquine level checking and counseling, they were able to greatly improve patient adherence. They brought compliance up to 80%. Retinopathy risk has now been linked to hydroxychloroquine levels. In 2020, Johns Hopkins published a very important study, the results of a first prospective study of 500 lupus patients that demonstrated that those with the highest hydroxychloroquine blood levels had the highest incidence of retinopathy. So taken together, rheumatologists are using a target range for lupus patients of greater than 1,000, but less than 2,000. And they are using the TDM to determine each patient's lowest effective daily dose. This is an example of our sample report. Of note here, the correct sample is whole blood, not serum or plasma. That's because whole blood measurements of hydroxychloroquine are more precise and stable because the drug preferentially binds to albumin and leukocytes. So serum and plasma levels are lower, and they're due to imprecision, they just don't work for TDM. So the sample can be collected at any time after steady state, which is about 6 months into regular dosing. There's also some PK data to suggest that drug levels are more representative of steady state if you can collect the blood at least 4 hours after the last dose. So hydroxychloroquine is a good example of how TDM can help you ascertain and improve patient compliance, as well as achieve better outcomes by achieving target levels of drug while minimizing long-term exposure and toxicity. TDM can hopefully help you titrate to patient-specific minimum effective daily doses. So in summary, these are the TDM options that we have for rheumatology. Our biologics monitoring test is known as DoseAssure, and as you can see here, we have the most complete portfolio of all the TNF inhibitors, adalimumab, infliximab, golimumab, certolizumab, and we're the only lab that measures etanercept and anti-etanercept. Also, these assays have been validated to work for each of the biosimilars that have become available, in particular Inflectra, Renflexis, and Avsola. So thank you very much for your attention today. And if you have any questions or even patient-specific examples that you'd like to share with me, you can send a message in the chat box, or you can reach out to me directly at any time in the future. Thank you very much.
Thank you, Dr. Yang. Right now, we don't have any questions in the chat, but if anyone has a question or comment, please feel free to post it in the chat. We'll make sure to get it addressed or answered. All right, well, thank you all for joining us today. And again, you will be receiving a link to the recorded session. We hope you found today's discussion of value, and please keep an eye out for the next in our series, the clinical relevance of anti-DFS70 antibodies, that will be hosted on November 16th of this year. Thank you very much and have a great afternoon.